Hi everyone, I'm Dr. Yong. I'm from Taiwan, from the Lingsing Hospital. Today I'm going to talk about the current concept on allergen immunotherapy, how AIT is performed, sublingual immunotherapy, and lastly I will talk about the side effect of AIT. This is a webinar in the JAVCA, the Junior Apache Allergy Relationship Forum and Cafe. So outline is one is how AIT is performed and sublingual immunotherapy and side effect of AIT. Lastly, I will talk my case in sleep and sublingual immunotherapy. So AIT, there's history from the subcutaneous immunotherapy and sublingual drops, sublingual spray, and finally we got the sublingual immunotherapy for the tablet. So reason for AIT, there are three reasons. Addition of AIT to pharmacology, pharmacotherapy alone will likely result in a more pronounced decrease in symptoms. Failure of pharmacotherapy to alter the underlying immunologic process, and patient may choose AIT largely to obtain lasting benefit, prevent the progression of allergic rhinitis, bronchiasma, and prevent the new sensitization. So AIT, how AIT is performed, the scheduling and dosing we got two phases. One is for the build-up phase. The second one is for the maintenance phase. And maintenance phase, there are traditional, cluster, and rush. And in my experience, I use the traditional for the every week and once to my office, to my clinics, and for about 3 to 6 months. And the second phase is for the cluster, and lastly for the it depends on the patient requirement for the traditional, cluster, and rush. So the dose selection, the maintenance dose of allergen immunotherapy must be adequate. The very low maintenance dose are generally not effective. So a consideration when missing extract is the need to deliver an optimal therapeutically effective dose of each of the constituents on the allergen immunotherapy extract. So we got many colors of the skin, from the red color, yellow, blue, and green. There are different concentration and dosage of the skin. Okay, in my clinical practice, I have to write it down the immunotherapy sheet. I have to record the dosage, concentration of the AIT of each patient. So I have to write it down for the erythema and the wheel and the site location, the local reaction of the patient, so that I can remind me to do the this recording. So outline the second one is sublingual immunotherapy. So there are sleep tablets, and they are covers most common respiratory allergies. We got the for the ragweed, for the grass, and for the house dust, my tablet and sleep. Oh, okay. I want to talk about the house dust my sleep tablet. Nowadays there are only one brand that there's for the 12SQ HDM, the tablet sleep in Taiwan. So there are approximately 15 microgram group 1 allergen and 15 microgram group 2 allergen for the P1 and the P1, the F1 and the F2 and the P2. So how we use it, the slit. So make sure your hands are dry before handling the medicine, and take a medicine like this. Tear off the strip marked with triangle at the top of the pack, and tear a square off the pack along the perforated lines. The third one, do not force the medicine through the foil. Doing this may damage it because it breaks easily. So instead, fold back the marked corner of the foil and then put it off. And finally, remove the medicine carefully from the foil and use it immediately. So lastly, place the medicine under the tongue. So allow it to remain until it has dissolved. Do not swallow for 1 minute, and do not eat or drink for at least 5 minutes. So how about the onset of sleep? The onset of effect is around 4 to 8 weeks. So assessment in environmental exposure chamber after treatment initiation. So we have to assess 12 to 16 weeks. Yep. in my experience, the patient will got improvement after 8 weeks of treatment and 49% improvement in rhinitis symptoms. So for my experience, the patient will how long will the sleep will take? So from this study, decrease in total combined rhinitis score, the TCRS in the active group during the AIT and 3-year post-HDM sleep. So I will suggest the patient to receive 3-year sleep treatment. So how about the biomarker? The HDM sleep increased specific IgG4. There's a clear dose-related increase in HDM specific IgG4 antibodies was found in studies for the active treatment. So the three-year treatment. So how I'm going to do in the first dose at clinics, I have to observe 30 minutes for the adverse drug reaction. So lastly, I'll talk about the side effect of AIT. So I have to observe adverse effect for 30 minutes. So what kind of symptoms I have to keep the observation? Breathing difficulty, tightness or swelling of the throat, difficulty on swallowing or speaking, fainting or dizziness, weak or rapid heartbeat, severe itching or flushing of the skin, and stomach pain or even cramping pain, vomiting or diarrhea. So the local adverse effect is around 4 to 7% in clinical trial. So the treatment-related adverse effects are the most common clinical reason why patients discontinue within the few months of sleep treatment in the clinical practice. So the most important is systemic reaction, we call it anaphylaxis. So in my experience, the 5 minutes after the AIT, the patient report oral swelling, throat itching, diffuse itching, and flushing of the skin with abdominal cramps. Anaphylaxis is highly likely when one of the following 3 criteria is fulfilled. For the most important, the reduced blood pressure after exposure to known allergen. 2 of the following of them occur rapidly after exposure to the immunotherapy, and the event is acute onset, involve the skin, mucosa, tissue, and both. So anaphylaxis, we have to very recognize the symptom and familiar with the for the first line therapy. So how about the numbers of reported suspected cases of anaphylaxis during the house dust mite sleep per year? In the year 2016 to 2019, there are 82 reports of suspected anaphylaxis to mite products and 6 anaphylactic shock. When anaphylaxis occurs, we have to prepare the most important medication. There is the epinephrine, or we call adrenaline. So first of all, we have to just for the resuscitation principle, there's A, B, C. Airway, breathing, and circulation. So adrenaline is the treatment of choice. We have to use it by the children and the adult. There's different dosage. We use the intramuscular injection over the site. And I have to prepare the H1 and H2 antagonists. Mostly I use the diphenhydramine. So corticosteroid is to prevent the protracted or biphasic anaphylaxis. There's no role in first 4 to 6 hours. So when do you require immediate attention? So we have to emphasize and educate the patient understanding symptoms require immediate attention. So for example, for the oral mucosa and the throat tight swelling, so when to call physician office, so we have to administer adrenaline auto-injector and proceed to the emergency room. So most frequent adverse event of sleep, they are local reaction in mouth and throat. For example, for the oral pruritus, throat irritation, edema of the mouth and tongue pruritus. So there is no increase in treatment-related adverse event in patients with uncontrolled asthma. Also, lastly, I'll share my experience of the sleep. The case 1, there's 18 years old girl presented with history of allergic rhinitis without nasal polyp. She experienced intranasal steroid nasal spray twice daily and intranasal decongestant as needed, and short course of prednisone within 1 year. So the nasal endoscopy, the congestion of bilateral middle turbinate, inferior turbinate, and thick whitish mucus. The allergen profile was positive to multiple allergens, including house dust mite. So after the slit house dust mite, at the 4th month, the VAS score 0 to 1 and no rhinitis exacerbation, no nasal discharge, and mild nasal congestion. And the patient taking the intranasal corticosteroid as needed. At the 12th month, the VAS score is 0 to 1 and very few nasal symptoms. The patient taking intranasal corticosteroid as needed, so there's no adverse effect. Now we can see the total IgE. The pre-slit is 455, and the 4th month 325, and the 1 year, the 12th month is 250. So there is some we call it local reaction at the 1st and the 2nd day. There's a edema over the sublingual area. So I just give in her antihistamine and use ice packing for this patient. Okay, the case 2, there's a 27-year-old female. She presented with history of allergic conjunctivitis and allergic rhinitis for 5 years. There's watery nasal discharge for 3 years. The nasal symptoms were not well controlled with intranasal steroid, nasal spray, nasal saline irrigation, and oral antihistamine. The physical examination showed a mild nasal congestion and few watery nasal discharge. The VAS score is around 6 to 8. The investigation, the total IgE is 1058 international unit. The specific IgE DIR-P and specific IgE for the DIR-F is class 6, is very high grade. So so finally I suggested that first the sleep for this patient. The first dose of sleep observation 30 minutes in my clinic. So their mouth itchy left ear and floor of mouth 2 minutes after sleep. The mouth swollen, uvula, lips of floor of mouth, so there is no wheezing, no stridor. So suggestion continue home-based sleep after the first time in my clinics. At 8-month follow-up, now and no any adverse effect from the medication, no nasal symptoms, the VAS score is 0, and the physical examination, no nasal congestion and no nasal discharge. And the VAS score is much more improved. So the last visit, due to the COVID-19 pandemic, so I used the telemedicine to contact with the patient. There's much more improvement of the nasal symptoms. So summary that how AIT is performed, scheduling and dosing, we have to build up phase and maintenance phase. And sublingual immunotherapy, in my experience, is more convenient and less side effect comparing with the SCID. Side effect of AIT, you have to be very familiar with the medicine and the anaphylaxis protocol. So I'm Dr. Yong from Taiwan. Thank you for my talk. The topic is current concept on allergen immunotherapy. Thank you very much.